and welcome to today's webinar of the U.S. Deprescribing Research Network. We're really excited to have you here to hear our presentation entitled The Drive to Deprescribe Initiative, Optimizing Medication Use in the Post-Acute and Long-Term Care Setting. This webinar is sponsored by the U.S. Deprescribing Research Network with funding by the National Institute on Aging. My name is Jennifer Chia. I'm a geriatric palliative care doctor at University of Massachusetts, and I'm accompanied by Dr. Ken Bookfar, who will help moderate the Q&A session. But before we get started, I want to cover a few housekeeping details. Due to the number of registrants for today's webinar, we have placed the phone lines on mute to reduce any audio feedback. So unless you are logged in as a host or panelist, your line is muted. However, we do welcome and encourage questions and ask you to use the Q&A feature on the Zoom webinar software to send in your questions. When you would like to interact with the presenter, please click on the Q&A bubble at the bottom of the toolbar and type your questions. If you would like your question to be anonymous, you can check the anonymous box before sending. Hosts will acknowledge questions during the final 15 to 20 minutes of the webinar, and after the webinar, you will receive an email with a short evaluation survey. If you have any technical or logistical questions, we ask that you submit these using the chat box and select the co-host, Jonathan Norton, to chat privately. Please make sure you're identified either by your name or participant ID, so the webinar hosts will be able to troubleshoot any problems that might come up. And finally, we'd like to extend a huge thanks to the rest of our background team, including Gabrielle Schiller at Mount Sinai, Jonathan Norton at Johns Hopkins, as well as Raha Shahrudi and Haley Schiff at UCSF, and Geraldine Puerto at UMass, who do amazing work behind the scenes to make all these webinars possible. And now, without further ado, I'd like to introduce our presenters we are really thrilled to have you here. So thank you for presenting. You can see we have a team of three. First, we have Dr. Jennifer Pruskowski. Dr. Pruskowski is a geriatric and palliative care pharmacist and currently serves as Associate Director for Education and Evaluation within the Pittsburgh VA Geriatric Research, Education, and Clinical Center as well. And she also serves as Assistant Professor and the Director of the Geriatric Pharmacy Research and Education within the Division of Geriatric Medicine at the University of Pittsburgh School of Medicine. Also presenting with her is Dr. Arif Nazir. Dr. Nazir is a board-certified geriatrician and currently serves as the Chief Medical Officer for Signature Healthcare in Louisville, Kentucky, one of the largest skilled nursing facility chains in the nation. He is also the founder and CMO for CareAscend, a digital nudge platform to enhance teamness among physicians, practitioners, and healthcare administrators within the post-acute and long-term care setting. And last but not least on their team is Dr. Chad Worz. Dr. Worz is a board-certified geriatric pharmacist and serves as the chief executive for the American Society of Consultant Pharmacists. ASCAP represents senior care and long-term care pharmacists and pharmacies across the country and around the world. So thank you so much for joining us. We're very excited to have you present Drive to Deprescribe.
Thanks, Dr. Teacher. I'm going to get started. Good afternoon, everyone. Thank you so much for spending some of your Tuesday after Thanksgiving with us. Thank you to the US DEN group, especially Dr. Boufard, Atija, Dr. Steinman, and I'm sure all the folks behind the scenes that made this happen as well. My name is Jen Pruskowski, and I have the honor of kicking us off to tell you a little bit about the Drive to Deprescribe initiative. I want to also say a huge thank you to Dr. Nazir and Dr. Worz for being here as well. But we are only three of a very, very, very large interprofessional group that has been working together to bring this initiative to life. So we'll talk more about them on a couple slides down the road, but I feel like I would be remiss if I didn't talk about them right off the bat. Today's presentation is going to be a little bit different than some of the webinars that all of you have probably come to expect from US DEN, because we are going to tell you a little bit about the opposite end of implementation research. Essentially, we're going to tell you about a real life initiative going on right now where we're using all of the Deprescribing research that's coming out, and some of it is from all of you on this webinar here, and how we are implementing it, kind of disseminating it across all of the post-acute and long-term care settings here in the US. Huge disclosure, myself, and I'm sure Dr. Nazir and Dr. Worz will not describe ourselves as card-carrying dissemination implementation scientists, but nonetheless, we're here to tell you a little bit about the lessons learned and some of the data to support this initiative. And we'll tell you a little bit more about how else this initiative can be helpful to you towards the end of the webinar. All right. So first with disclosures, none yet. I'm sure all of us on this call as a career goal want to have a disclosure on this slide. Maybe one day we can get a drug company to sponsor a Deprescribing talk. That's at least my goal. And because I am a federal employee, I have to formally say that these views expressed are not those of us, and they don't represent the views of the VA. All right, so we have 3 objectives for our next 45 minutes together. One, we're going to talk a little bit about the Deprescribing conundrum in the post-acute and long-term care setting. I'm sure some of you on this webinar have had the pleasure of working with patients in this very unique setting. But for those of you who have not, we felt that it would be valuable at least to talk a little bit about, again, this the kind of conundrum that we have in this setting. The second objective is we're going to present to you the initiative and talk to you a little bit about the goals, the origins, kind of what we've been doing over the past couple of months. And then lastly, we're going to present some of the interim aggregate data, and then mostly talk about the lessons learned that we've been kind of learning as we go along. All right, so first we're going to start with a little bit about the Deprescribing in this setting. So for those of you who are not familiar with the post-acute long-term care setting, essentially this refers to the care provided to patients after hospital admissions. And it can include a wide variety of settings. I'll go through some of them on the next slide for you. These settings include the nursing home as well as rehab centers. Long-term care refers to care that are provided to patients that no longer can be cared for at home. And this is typically nursing homes. But as you can see, I listed nursing homes in both the post-acute and long-term care setting because there is a little bit of overlap between all of these settings. So like I said, there is a wide variety, a very wide spectrum of post-acute long-term care settings. And this is important because when you talk to other researchers, other clinicians that practice, educate, research in this particular setting, it's important to recognize that while there are overlaps, there are also unique differences and intricacies to each of these components. So this slide is a very crude overview of all of the settings included in the post-acute and long-term care group. To orient you to this slide, you can see that the y-axis refers to personal care needs. So the needs of patients for their activities of daily living, bathing, eating, etc. And the x-axis refers to the illness or medical care. So how unfortunately sick a person is, how much hospital, nursing care they really need. And so the post-acute long-term care setting goes anywhere from a person who requires a high level of personal care needs, requires a high level of activities of daily living support, to a high degree of medical complexity. And again, like I said, while all of these settings fall under the post-acute and long-term care setting umbrella, they each have their own set of regulations, intricacies, cultures. And again, for those of you who are interested in working in this setting or do already, I'm sure you guys all can appreciate that each of these settings are a little bit different. This is the slide that I'm sure all of us feel very comfortable with and know very well. Our long-term care patients, those that require a higher degree of personal care needs, higher degree of support for activities of daily living, as well as lower to moderate medical needs, are unfortunately the most susceptible to medication overload or polypharmacy, whichever terminology you subscribe to. Just briefly, the data suggests that these patients take about 11 medications a day, and about 90% of our residents take greater than 5 medications or 10 medications each. But that's really not the whole story, right? The reason that we talk about the long-term care setting as the most vulnerable is that they unfortunately are the most susceptible to any type of drug-induced morbidity or mortality. To put some numbers to that, the data suggests that there are about 2 million adverse drug events per year in this group, and approximately every 1 in 7 nursing home residents are hospitalized each year. And while the prevalence of potentially inappropriate medications is about 43%, again, we know that really our biggest issue is that these adverse drug events cause a lot of harm to our patients, causes a lot of disruption to our care setting, and it's just not fun for everyone. Oops. And while the long-term care setting in particular is perhaps the most at-need population for deprescribing, it also is potentially the hardest to implement deprescribing. And there are several reasons why. I'll go through them briefly, but I'm sure we could talk about this for an entire hour. Perhaps the largest barrier to deprescribing implementation is the lack of evidence-based literature. This setting in particular is most often excluded from clinical trials. For example, many of our nursing home long-term care patients are unable to provide consent. It sometimes is challenging to get consent from a family member or whatever power of attorney there are. 2, this group also tends to have multiple comorbidities that for one reason or another would exclude them from a trial based on an inclusion-exclusion criteria. The second largest barrier is perhaps this fragmentation of care. So while a nursing home provides a considerable amount of medical support to a patient, it's not supposed to be a hospital. It's supposed to be a home setting. So while there are physicians and providers on site daily, they are not meant to be interacting with the same residents every single day as would a physician in a hospital doing inpatient rounds. In fact, CMS, which regulates all of our nursing home interactions, essentially only requires a physician to see a patient once every 60 days. So again, it's supposed to be like home, as if you were ambulatory, you come and see your ambulatory physician every other month. That's kind of similar to what we have here. And then thirdly, and this is arguably, if you work in a nursing home in the long-term care setting, this might be perhaps the barrier you think is the largest, and that's workforce strains and shortages. Unfortunately, not only do we suffer from the need for additional geriatricians, we also have considerable turnover in bedside nursing aides. The largest reason for that is the starting salary for a bedside nurse in a nursing home long-term care setting is very similar to if you would work in retail or perhaps the restaurant industry. So a lot of folks choose other professions over caring for our older adults in nursing homes simply for that reason. So the deprescribing conundrum in this particular setting is that, as we've said, it is arguably the most at-need population for deprescribing, but it's arguably the most difficult care setting to implement. So we have 2 societies that have been developed and geared towards improving the care of our post-acute and long-term care residents. And one of them is the Society for Post-Acute and Long-Term Care Medicine. Just briefly, this society is essentially the only medical specialty that represents this wide, vast, slightly heterogeneous group of providers. And the mission for this society is essentially to promote and enhance the development of medical practitioners and leaders within this care setting. And as you can see, the second mission, most importantly, is, as you can see, it's dedicated to defining and improving quality for members, patients, families, and staff. And that's really the most important, because the Society for Post-Acute and Long-Term Care Medicine is the group that has sponsored this Drive to Deprescribe initiative, and you'll learn a little bit more about them on the next slide. that this initiative would also not be as successful as it already is without the help of the American Society of Consultant Pharmacists as well. And although I am very familiar with ASCAP, I'm very lucky to have its chief executive on the call. So Chad, feel free to jump in and talk a little bit more about ASCAP.
Sure. So ASCP is an organization that does represent pharmacists and pharmacies that serve a senior care population. Its history goes back more than 50 years. And if you think back to the late 60s, it was a time when really congregate care settings, in particular nursing homes, which were probably more like rest homes at that point, were starting to come into existence, and community pharmacies were exploring how to service those types of environments. So ASCP has kind of served in a role of broadly as in medication management for over 50 years, innovating everything from compliance packaging and 24/7 services to these newly forming nursing facilities through that 50-year period to evolve to more clinical practices as the population aged, as medications became more ubiquitous in older adults. A lot of the focus shifted toward clinical management of polypharmacy and deprescribing tactics. And it was kind of codified into, consulting was kind of codified into existence in 1987 as the OBRA bill established monthly medication review in skilled nursing facilities as a condition of participation, meaning that a pharmacist has to review a patient's medication record every month in every nursing facility, every calendar month. So that's where ASCP sort of serves as a support mechanism for pharmacists and pharmacies that participate in taking care of those individuals. Just quickly, over time, that's still consistently evolving. As we know, nursing homes have changed in 50 years. We have rehabilitation centers. We're seeing patients that are transitioning from hospital to nursing home to home. And we're starting to see more of our members participating in community practice, dealing with older adults with medically complex issues and medication issues in the community population as well.
Thanks, John. So moving forward, we're going to talk to you a little bit about the Drive to Deprescribe initiative. And this Drive to Deprescribe initiative has been sponsored by the Society of Post-Acute and Long-Term Care, as well as ASCAP. And I'll pass it off to Dr. Nazir to tell us a little bit about how it came together.
All right, thank you so much. I would really like to echo Jennifer's comments on, we just feel privileged to be here, and some of the names I recognize really well from the literature. So it's just an honor to see you and virtually interact with you. Really a lot of respect. Without all the work this network leaders have done, we would not have any of the important literature and guidance we actually try to use day-to-day practice around polypharmacy optimization and deprescribing. So thank you for that. So my name is Arif Nazir. I'm a Chief Medical Officer, Signature Healthcare geriatrician by trade. And before I was at Signature Healthcare, I was a clinician working in nursing homes. And I took my job very seriously, like many of you I'm sure do, particularly when you work around frail individuals. And it kind of always was a problem for me in regards to how do I manage my time whenever I had a new patient or whenever I had a detailed review of my resident, which was overdue. Like usually in once a year, you would do a detailed review of your resident, because you had to go through this dang list of medication. And so many times this list of medication was so long that you were really, really stuck that, how many patients you're going to see, how you're going to get your job done, are you going to be able to do justice, and, what are you going to teach your patients about all these pills and why they're on them? So for me, it was always a sore thorn on my side. How do I deal with it? But even though it was one of the most fulfilling things I could do as a clinician was to talk and educate and try to optimize and deprescribe, still it was really making my job really hard. And then when I joined Signature Healthcare as a CMO or as a physician leader, then this became a survival thing for me in my job is how do I help Signature Healthcare, a large organization, really improve quality of services they provide? And one of the things which I knew I could really contribute to was how can I make Signature Healthcare improve its practices around medication optimization, and deprescribing became just really a go-to strategy for me to promote as a physician leader. And that's when I start looking around is like, what kind of collaborations can we build as many leaders who are trying to improve care around polypharmacy deprescribing? And that is where organizations like ASCAP and AMDA or Society of Post-Acute Long-Term Care became really, really very important. I was the president at that time and was lucky to interact with a group at Society of Post-Acute Long-Term Care Medicine called the Leadership Group. And this leadership group met every quarter and mostly comprising of chief medical officer, chief nursing officer, other executive leaders, and pharmacy leaders from different organizations coming together every quarter to talk about really healthcare issues which were relevant. So that platform was very helpful for us to kind of create a sounding board to get ideas from others. And when we made this a topic of conversation, we quickly realized that it was not just a few of us who were struggling with this issue. This is really a global national issue. And that is where, as the president of AMDA at that time, it was very easy for me to say, you know what, man, this could be an initiative where we could create some cheerleading and some collaboration. And we could really help, as you can see in the point 4 there, move the needle on a universally significant issue with a measurable impact. That's the beauty of anything you do with medications, that you can measure it, right? I mean, quality of life, tough to measure, but pills, anybody can count. I think it really quickly became a very focal point of conversation among many leaders who were on that group. And that's how this initiative emerged in concept. And as Jen will share with you on one of the coming slides, that yes, the idea emerged a couple of years ago, but this dang pandemic came in the way, and of course things got delayed. But maybe it was the right thing, right? I mean, it gave us the time to really think it through. How do we take this initiative forward, and how do we create energy around it? Now, the reason, as one of the leaders of Society of Post-Acute Long-Term Care Medicine, and also just a leader in the setting, one thing which I'm interested about this initiative is not just because I'm interested in cutting down pills, which I am, but what I'm interested is in implementation science. And many of you being implementation scientists here, and I fully agree with Jen and Jennifer, is that none of us are formal implementation scientists like many of you are, but we indeed are implementation soldiers. We do have to get our hands down and dirty in implementation every day, right? I mean, how can you not be part of it? But we in day-to-day implementation in nursing homes, it's a humbling job. It's one of the most complex systems, the nursing home setting, and we all actually get very humbled by implementation failures. How do you implement a change in a setting like a nursing home where staff shortages exist, resource shortages exist, there's lack of data, there's lack of incentives? How do you bring about a sustained change that can then be benefited from in that setting? So that is the question which a lot of people, scientists, clinicians, leaders try to answer in the nursing home science. And I think what we all are excited about this initiative is that the lessons we are hopefully going to learn from this initiative is going to lay ground for a whole lot more implementation in the future around other areas which are so important. Think about happiness, quality of life, falls, well-being, right? There's so many issues that we need to address in geriatric frail populations, and we're really excited that the energy this interprofessional group brings together could really become a template for future work also. So with that, let me just go to the next slide, which I think really is one of the most important slides in the slide deck, is that right off the bat, our conversation very, very helpfully were that we have to nail this in a very interprofessional way. The days where, because AMDA, or Society of Post-Acute Long-Term Care Medicine, is mostly a physician organization, we quickly recognize, and those physicians, I'm very happy, quickly recognize that the days where a physician with a red cape can save the day are over. I don't think there were ever any days like that, other than maybe an operation theater ER room where a physician may have a little bit more significance. But I'm the first one to say that physicians carry no more value than the whole team together. I mean, and include that in there, the frontline nurses aides who barely get paid anything, as Jennifer said, to physicians, to nurse practitioners, to pharmacy partners, nurses. Everybody on the team has a very, very important role to play if you really want to have a successful implementation project in a nursing home. We all have been humbled by that. And I think that was the best thing that came out of the conversations, that this initiative will only survive or be kicked off or will be beneficial if we can create an interprofessional energy through this initiative. And I think that's one thing which we thought through really well. And I think the pandemic kind of helped in just that way, that we were able to think it through more. And we were able to garner a lot of great support from a lot of interprofessional leaders. And this slide, again, just gives you a little bit of a sample to show you that how interprofessional this group is. And as you can see, the 4 blocks here represent all different 4 specialties. And you can see on the right bottom corner, my favorite group is the chief nursing officers, the nursing teams. And Kathy Owen, Annette Winsler, many other nursing leaders have been great partners for us to kind of think this initiative through and make sure that we do not make this unscalable or unrealistic. And it has to meet the needs of the clinical workflow of the staff. So, I just wanted to take a few extra minutes on these 2 slides just to share with you that, it's not that simple to implement a change or a behavior change in nursing homes. You really need to come up with some very, very outside the box interprofessional ideas. And I think the purpose of this D2D group is not to be the experts, but to be the facilitators and the cheerleaders so that we can keep the momentum and the energy going on this initiative. Otherwise, in nursing homes, it becomes really easy to get distracted by whatever the regulators want us to focus on or whatever is the big news. We can easily get distracted by that, and proactive things like looking at medications proactively and trying to optimize them, even though when there's not even a problem in a resident who's smiling and laughing, you're still looking at their pills. Okay, you can get distracted from that. I think the purpose of this group and this initiative is to remind everyone that harm happens every day. Even though if a patient is smiling, if they're taking extra pills with beer list or harmful, there is some background harm that is happening, even though the patient may not be feeling it, but in the future, it's going to kind of manifest in some kind of a bad outcome. So let's be proactive and not reactive. So I think that's one thing which this group has done really well. Now, talking about implementation of a big initiative like that, which includes more than 4,000 nursing homes, we really required a lot of implementation energy. And for that, we were very lucky that we were able to find Jennifer to lead this role. And Jennifer, as the implementation champion, I would really request for you to kind of go through some of the first few implementation steps we took as a group.
Sure, Dr. Nazir. So for those of you who are card-carrying dissemination implementation scientists, I think it's important to start that we initially gained support from the largest and perhaps the most important stakeholder group, the Society for Post-Acute and Long-Term Care Medicine. It is also referred to as AMDA. Previously, it was referred to as the American Medical Directors Association. So you might see AMDA abbreviated on some of these slides. Dr. Nazir does not like it when I call him the leader of this group, so I will call him the coach. Thank you, Chad, for that. And essentially, Dr. Nazir, as the president of this society, reached out to several other large influencers and core stakeholders within our setting in January of 2020. I should also mention, and a huge thank you to Dr. Steinman, because he is also peripherally involved in this group as well, and he really serves as the main content expert for all of this as well. In February of 2020, we, as in some of the core work group members, met in person, yes, mind the date here, met in person in Maryland to discuss how we would develop such a large initiative as this. And then, as you can see, that next month is when the pandemic hit. And unfortunately, our setting, again, the post-acute long-term care setting, was perhaps the most challenging during COVID, only because we had several other issues that only come in this setting when you have a pandemic like that. So unfortunately, the group was put on hiatus for a couple of months, but we came back together in October of 2020 and again started thinking about how to bring and how to really bring this, this goal to life. I'll talk more about kind of the intricate details that we went through in a couple of slides. In May of 2021, we had our first initial Drive to Deprescribe kickoff. And just to give you a timeline, this initiative has a tentative end date of July of 2022. So we're trying to get most of this work done essentially between May of 2021 and the end of June 2022. So about a little more than a year. So the first thing that we did is sat down and we wanted to come up with a mission statement. And I'm sure all of you are looking for the SMART parts of this mission. But we decided to focus on a reduction of scheduled medications in long stay patients by 25%. There were several reasons that we chose these numbers and these parameters, and I'll go through them briefly. Number one, we decided to focus primarily on the long stay patients. These are those patients that fall into the long-term care, predominantly nursing home setting. Briefly, without going on a long diatribe, we chose the long stay patients because our post-acute residents sometimes are not within our care for long periods of time. Many, if not most of them, are cared for under different regulations than the long stay patients. And we really wanted to show an impact with this initiative. So we decided to focus on the long stay patients. Number two, we decided to focus only on scheduled medications and not PRNs. The reason for this is in the long-term care setting, PRNs are not as frowned upon as perhaps in other settings. As I mentioned before, the long-term care setting is meant to mimic a nursing home setting. So the resident is not supposed to need to interact with a provider or a physician on a daily basis. So a lot of times nursing homes will decide to keep PRN medications in a list to essentially give our bedside nurses, the folks that really interact with these residents on a daily basis and really are the ones that care for them on a daily basis, the decision-making capacity to think about what kind of medications or what kind of care that resident really needs. We also chose 25% for a very specific reason. As you probably remember on a few slides ago, the average number of scheduled medications for a nursing home resident is usually about anywhere between 10 and 11. So a 25% reduction meant that we would reduce anywhere between 3, maybe 4 medications per resident. And as we'll talk about, that was deemed a feasible reduction by all of our work group members simply because of what medications we were seeing, what medications were prevalent in the data that we were seeing, and we'll talk more about the data in a little bit. But the second mission of this initiative was really very similar to the US DEN in that we wanted to create a deprescribing culture, a deprescribing environment for the providers in this setting. So we wanted to provide the tools, the support, and essentially the community so that any nursing home provider, post-acute long-term care provider would be able to reach out to other content experts, other potential mentors, et cetera, to do this work in their respective homes. And the particular reason we decided to do this is many post-acute long-term care providers feel very isolated from either a larger healthcare system and especially other post-acute long-term care providers. Just briefly, there are over 6,000 nursing homes in the United States. They each have their own cultures. They each have their own little set of fun, I'll just say culture again. And we usually make the joke that when you've come to one nursing home, you've only seen one nursing home. So again, we wanted to create that community so that all these folks had other folks to reach out to. The other thing that I will mention on this slide is why we came up with the name Drive to Deprescribe. So for those of you, again, that create initiatives, who are D&I scientists on this call, marketing publicity is very, very important. And one of our main calls within the core working group was focused solely on what we would call this initiative. As you can imagine, we came up with many, many different names. We settled on Drive to Deprescribe for many reasons, but these are the largest. One, we chose the name Drive, not only because it is a D, like deprescribing, but we wanted to reinforce that deprescribing is not a one-stop shop, that you have to continuously strive for progress, just like you're driving. You're always moving forward, always looking forward, and having a little bit of a look in your back mirror. So we also chose the owl, as you guys will see on some of the slides, because as all of you know, the owl kind of represents wisdom and knowledge, and we wanted to create a culture around that we were all learning together And while this initiative was geared towards clinicians in this environment, we have said multiple times to our larger group that none of us are experts. We all are learning here, and we try to create the environment where we all learn from each other. Again, because if you see one nursing home, you see one nursing home. And so what might work for one may not work for the other. So here are the components that we came up with for the Drive to Deprescribe initiative. The core component of our initiative are what we call the virtual learnings. These virtual learnings are monthly, and they go back and forth between what we call webinars and progress check-ins. Our webinars are what you would expect. They are essentially 30 to 45 minutes of a lecture style, although we do encourage active participation during them to teach our group some type of skill or some type of knowledge pearl. The progress check-ins, however, are very different. This is when we invite experts from respective nursing homes, respective post-acute centers to talk about what specific initiatives they have going on, or we open it up for discussion amongst the group, again, so that we create a culture of learning from each other. The second largest component is what we call the online resources. We have, again, we are very lucky to have the support of the Society for Post-Acute and Long-Term Care Medicine, who run our D2D website. I'll show you a screenshot of that in a couple of slides. They also run our social media and promotional toolkit, and they have also been kind enough to essentially be the triage center for all of the materials that either the core working group has developed or we've received from other respective D2D members. For example, we, in the beginning of our initiative, created sample emails, email templates, and or letters for prescribers and families. So if our D2D members wanted to see an example of how to talk about deprescribing to families and other providers, they were more than welcome to use that. And then the third component is essentially the aggregate data metrics. We knew right off the bat that it would be very important for us to be able to track our progress, especially within only a one-ish year time frame. And we'll talk more about the data moving forward as well. So here is just a breakdown of our Drive to Deprescribe initiative. As you can see, it is a healthy interprofessional mix. What you're seeing on the slide here is that right now we have 657 individual registrants as part of our larger group. Some of them are post-acute long-term care society members and some of them are not. But again, the important thing here is to see that not only do we have a quarter of physicians, 35% of our participants, our members, are what we call allied health members. So these are our non-prescribers and essentially non-providers. So these are our social workers, our chaplains, our bedside nursing staff, etc. And then another important thing on this slide to mention is that 23% of our registrants are other leadership positions. So these are folks who essentially are in the executive suite of these buildings. As you can imagine, this is important again when you're developing individual initiatives for individual nursing homes to have the support of their senior leadership on site. So as I mentioned, the Society for Post-Acute Long-Term Care Medicine has been kind enough to not only sponsor this initiative, but to take care of our social media presence as well as our website. So here you're looking at a screenshot of the homepage of the website, and the URL is at the bottom of the screen for those of you who would like to visit the website later and learn even more about what we're doing that we can't talk about in this webinar. This essentially is where the excited parties can log on, join the group, register for our meetings, our webinars, or our virtual check-ins, find all of our online tools, and as well as to help as well as a place to submit their own data if they would like to learn more about how they're doing in the initiative as well. As you can see, we have really focused on the data as part of this initiative. So one of the first things that our participants need to disclose is which of their pharmacy partners, provide them the physical medications to their homes, and therefore the data for what type of medication use they have. And so, although Chad will talk more about this later, I want to mention that this is important, especially for us, because in the long-term care setting, getting data can be a little challenging, and I don't want to talk about more because I'll spoil Chad's part of the talk. And then briefly, here are just some screenshots of our virtual learnings. On the left, you'll see one of our slides from our webinars, where we would talk about how to design a drive to deprescribe intervention. On the right-hand side is just a screenshot of one of our progress check-ins, where we would ask other experts to come in and talk about what strategies and successes and secrets they've had in their respective homes. And as you can see, again, we as the core working group try not to talk as much as possible. We try to just be the facilitators for most of the discussion. And then here are just some example presentations. We talked at the beginning of our initiative about identifying champions and stakeholders. We moved forward to how to develop a deprescribing intervention and process. And it's important to mention here that most of the resources that we have provided to the Drive to Deprescribe initiative have been from deprescribing.org. Only because, again, our main audience are clinicians. Most of them would not identify themselves as educators or researchers. We also felt strongly as the core working group to use the deprescribing.org materials, particularly the algorithms, because while I'm sure all of you would agree, we can develop slightly different deprescribing interventions for respective purposes. We wanted to give our members, our group, a kind of gold standard to start from. And then if they wanted to make changes moving forward, they could do that. In the beginning, I have to admit, I think I felt very strongly about giving them multiple options and kind of the pros and cons to each. And I'm very grateful for our other working group members that kind of fought against me and thought that it would be better for this group to get the gold standard and then make changes later. We have also felt very strongly about, again, getting feedback from our participants. And so one of the first asks that we had from our members was to give them some type of communication map around deprescribing. And so that also became one of the first webinars that we presented as well. And then what we focus on in each of the webinars as well is one of the deprescribing.org algorithms. We go through patient cases and we talk about how to identify those deprescribing eligible medications, how to taper them appropriately based off of that person's specific case. And then again, how to talk to patients as well as other providers in this fictitious case. This is what I'll mention. For those of you who do not work in this setting, it's important to recognize that while we talk about fragmentation of care in that a primary care provider does not see a long-term care resident on a daily basis, they shouldn't. They should only see them every 60 days. Nursing home residents can also receive care from providers that are not part of the nursing home healthcare system. So for example, a nursing home resident may well in fact be transported from the nursing home to an outside cardiologist that has no affiliation with the nursing home in any shape, way, or form for their respective cardiology care. This is important because because this happens a little bit more than I would like to admit, it sometimes becomes challenging for post-acute and long-term care providers to coordinate deprescribing because we don't speak to each other. Sometimes our healthcare records do not match. And a lot of times we are trying to catch these providers on the phone or via email, et cetera. And so talking about how to talk about deprescribing, as well as talking about why it's important and why we think so much about deprescribing this setting can be a little bit challenging when you are talking to some of those outside providers as well. And then, like I said, we ask for feedback from our providers, our members at each webinar and virtual check-in. And we've really taken this to heart. As I said, we review this feedback form pretty intently, and anything that our members ask for, we try our best to give them. So that's kind of the core components of the initiative. And so an initiative would not be an initiative without data to support its success. So I'll pass it off to Chad for this next part. Great.
Thank you, Jennifer. As mentioned at the beginning, I'm Chad Worz of ASCP. I'm actually, and I want to kind of over-acknowledge all the other team members, I am standing in for Michael Sinke, who's a Senior Vice President of Pharmacy for Genesis Healthcare, one of, if not the largest nursing home chain in the country. And one of the things that we had to accomplish in this process was to collect data in a way that represented the impact of what we were trying to do from an education perspective and from a resource perspective. And I don't know if I have control of the slide.
No, Chad, I'll do it for you. I'm sorry.
Okay, next slide. So we partnered with 3 of the larger pharmacy providers, PharMerica, Omnicare, or CVS Omnicare, and Consanus, which is a large long-term care pharmacy in the Midwest and West of the country, to collect some data that could at least give us a barometer of what the impact might be having across the country with our efforts. So it was done in some ways from a simplicity standpoint of dealing with 3 larger pharmacies where we could collect bulk data, but certainly that this effort is not limited by the practitioners or the participants from the nursing facility standpoint in any sort of setting with any pharmacy. But this is how we collected the data. Next slide. And this is the data so far. So we're looking at 2 quarters. And what I really like about my role as somewhat of a stand-in and my role at explaining this is I've seen this kind of impact before. I was a consultant pharmacist and worked in senior care pharmacy for 19 years before coming to ASCP. And this is consistent with what we see when we make efforts from a global perspective, from a population perspective. So if you look, this is 2nd quarter data of 2021 and 3rd quarter data of 2021. We were looking at information from 814 facilities in the 2nd quarter and 823 in the 3rd quarter, approximately 66,000 patients in each quarter. And you can see that the scheduled medications per patient initially was 8.17, which serves as our baseline for the project. And through the first data collection period, which would be the 2nd quarter, the 3rd quarter, it came down to 8.09. And I think a lot of people's initial reaction to that is, well, you know, that's nice. The trend line is great. The way you put it on the screen is great. It shows a dramatic reduction, but that's not a lot. And I want to caveat that from 2 perspectives. One, these are the kind of population moves we tend to see in long-term care facilities when we're looking at big populations. We know that there are facilities that are very aggressive and active, and we know that there are facilities that don't have all the resources or the collaborations necessary to make big movements, and ultimately the average comes out a little less maybe than we would have anticipated or desired. But the reality is, if you take that 0.08 difference in medications per patient across those 2 quarters, you're talking about 5,400 medications removed from profiles. And ultimately, in every 12 patients, we're removing at least 1 medication. Now, again, we think we can do better than that, but in terms of the initial data pool of the first 2 periods of our intervention, we feel like this is progress forward. And I think it's good momentum as we move toward the 2nd and 3rd phases of our data collection. And the other thing is to take into account is that we don't do this activity in a vacuum. So we're making an emphasis and a priority on education and empowerment of the multidisciplines across long-term care facilities. But at the end of the day, we're dealing with other things, primarily a pandemic. And if you think about the time periods by which we collected our first data points, the 2nd quarter of 2021 is really the beginning of maybe a predominantly vaccinated resident and staff for COVID-19. You have the reintroduction of some of the outside professionals that would enter nursing facilities and do their job as that maybe they normally did before COVID. And that all has an impact on medication utilization. I think if we were looking back in 2020, we would see that medication utilization swelled in some cases, particularly in some classes of medications, especially related to psychoactive meds and dealing with isolation issues, and the fact that even within the facilities, residents couldn't meet with each other, couldn't have meals with each other, couldn't have visitors. So in dealing with that and seeing us kind of emerge from this pandemic in some ways, this is kind of an expectation of what we might see in a change in medications per patient. And maybe more importantly, the fact that it's coming down is indicative of some momentum. Next slide. If we break that down by category, of course, these are secondary endpoints. We know that we don't have the power to make really assertive statements about changes in these different classes, but they do show us a little bit, again, information on the dynamic that we were dealing with and we continue to deal with in long-term care. So if you look at the improvements that were made, you'll see improvements made in proton pump inhibitors. You'll see improvements made in the percent of patients on sliding scale, the percent of patients on sulfonylureas. Diabetes is a big place for polypharmacy and a big opportunity for deprescribing, especially from a safety perspective. But maybe more impactful is the fact that through the pandemic, we looked for ways to decrease the amount of touch points that maybe nurses had or nurse aides had with patients. So things like sliding scale that may have been a challenge for us to eliminate in long-term care facilities before COVID became a little bit easier because the recognition that, yeah, I don't want to be doing finger sticks. I don't want to be applying insulin in a sliding scale fashion, not just because of the relative safety issues, but also because of the high touch that creates and potentially the infection control risk that exists. So you'll see some changes as it relates to that. If you look at changes that may have gone in the other direction, the percent of patients on trazodone and antipsychotics did go up during that time frame, even though the overall reduction was lower for all drug classes. And I think that's just us feeling our way through this reintroduction to more aggressive psychoactive medication management in long-term care facilities following an environment where we probably created a lot of psychoactive med use because of the conditions in the pandemic as it related to visitation and isolation. But overall, progress, and certainly some key points in key drug classes that we can point to as we continue to track data in this effort. Next slide. So our interim lessons learned from the first data pools is to facilitate versus lead. Certainly, again, we could pull out facilities and look at those that were very aggressive and assertive at doing this. But the reality is we need everybody to participate, not only everybody within the facility, but everybody around this industry as a whole, so that we don't see the anecdotal improvements in some facilities versus others. And we have to continue to emphasize that as we go forward. Certainly, we value the interprofessional team, as you can see from some of Jennifer's data. We're talking about individuals that are participating across disciplines, anywhere from the administration of the nursing facility to the CNA level staff. And that's important because everybody has a role to play in the identification of opportunities to deprescribe. Certainly we focus more on categories that move more easily. You've got to start with good versus perfect, and we have to look at categories that is the low-hanging fruit and the opportunity to deprescribe. Any movement, any deprescribing movement is going to have an impact on the rest of the medications on that patient's profile and maybe the trigger that leads to more reductions in some of their medications. And certainly we need to focus on antipsychotics and psychoactive medications and anticholinergics as they affect people's cognition, because that's always going to be an ongoing issue that leads to polypharmacy. And again, especially coming out of this pandemic, it needs to be a strong focus going forward. Jennifer?
Thanks, Chad. Sorry about that slide. I was trying to just click on my screen. For the sake of time, I will just be mindful because it's 55. So in regards to next steps, we will be continuing this initiative, as I said before, sorry, my video's off, until July of 2022. And we'll continue to monitor the aggregate data, and we'll present kind of the next interim results at our 2022 annual meeting. Here are the pearls for today, but as you can imagine, they're kind of broad, so I'll skip those. But the last slide is for those of you who are practicing in the post-acute long-term care setting or are interested in researching in this particular setting, please consider joining the initiative. Please consider reaching out to us for other potential collaborations. We've already worked with some researchers to get them connected to folks in particular settings and particular geographical areas that are of interest to them. And we are more than happy to be that kind of triage center for you as well. And if you would like to learn more about the initiative, feel free to take a look at the website, and the URL is there. And then lastly, we wouldn't be anywhere without our AMDA staff. So this is our huge thank you to them who behind the scenes make this work happen. And thanks to the other presenters and all of you. So we'll take any questions. Thanks, Dr. Profar.
Thank you all, Dr. Pruskowski, Dr. Worz, and Dr. Nazir, and such an important initiative. Great that AMDA is supporting it so strongly. So we do have a few questions. One is, can long-term care facilities outside the U.S. participate?
So I can take that. That answer is absolutely yes. But of course, just to mention that the 3 large pharmacy partners that we are extrapolating data from are in the United States. We hope in the future to create a pathway for other long-term care settings that do not receive their pharmacy support from those 3 companies to submit their own data and kind of become part of the larger initiative moving forward. And we're working out the kinks on how to do that now. So the answer is yes. And if you have and if you would like to submit your data, let us know. We'll figure out a way to do that as well.
And are the materials that you've shown available to the public to use?
That's a great question. So the answer is you need to register as a Drive to Deprescribe member in order to access our resources. However, you do not need to be a member of the Post-Acute Long-Term Care Society in order to access those materials. So the answer is they're not public, but it's not hard to get to them if you are looking for them. I don't know if Dr. Nazir wants to add anything to that.
No, I mean, you said it. You said it. It's open to everyone. Yeah. You can even join our webinars. All you have to do is give your information, and you're done. Yep.
Yeah.
Do you have other than nursing homes? Do you have other settings participating, like home-based care settings, or let's say assisted living?
Great question, Dr. That answer is yes. And I'm sorry we don't have the breakdown for you. The last time I saw the data from AMDA, I think it was only a small percentage, maybe 10, maybe 20% of our members have self-identified as providers in those other kind of post-acute, non-long-term care settings under our umbrella. But mainly the reason for that is we've been very clear that the initiative is geared towards the long-term care setting. But there is a small minority of participants in those other groups. We welcome everyone, but of course we had to focus on someone, so.
Great. I want to be mindful of everybody's time. There are a few questions in the question and answer. Maybe you can see them. But I do want to say, again, a big thank you to our presenters. Again, just can't emphasize how important this is. This webinar will be posted on the US Deprescribing Research Network website. Attendees will receive a short evaluation survey that will be emailed shortly. So you take a look at your email and your junk email. We do have another webinar scheduled for January, and the date is January 18th, I believe. So January 18th, 2022. Keep an eye out for that. I also want to just have our audience aware of a few opportunities to apply for support from the U.S. Deprescribing Research Network. If you go to the website, there's an upcoming request for applications to become a member of our junior investigator intensive. This is support for junior investigators who are interested in deprescribing research. So take a look at that. Again, thank you, everybody, and especially to our presenters and our support staff, and have a great day.
Thank you.